my copy.
Absolutely.
So thank you very much for feedback on this case. So this is a 17-year-old Caucasian female who is actually the daughter of an acquaintance of mine. I see her here at our Nicholas County site where she is a senior. She does half days here. She did start seeing me last summer in August for depression. She came in with her mom. She reported a history of depression for quite a few years, like maybe 3 years, but she had never sought treatment or care before. She came in with her mom because her depression had worsened and she was actually having some suicidal ideations. Since then, I have seen her and tried her on several different medications. She's also been in counseling with my colleague Savannah Thomas, who actually is on the call. She joined after introductions, and I'm hoping she'll be able to give some insight on this young woman. You can see there on the case presentation form that back in August, she had normal lab work. I noted when I was preparing the echo case form that she's lost 16 pounds since August, and I haven't followed up on that because I just noticed when I was preparing the case form. It was not obvious in seeing her. So I'm not sure what that is about. In August, her TSH was normal, however, and she did have a normal physical exam in August. You can see her PHQ score starting in August was 24 out of 27. And I did put her on Lexapro at that time, 10 milligrams. Then after a certain amount of time, I increased it to 20 milligrams, but we kept her on Lexapro for over 6 weeks, and she really did not report any improvement. And was having some anxieties. So in October, I switched her to venlafaxine, which I gradually increased from 37.5 to 150 milligrams. She reports no improvement on that, but you can see what's interesting is her PHQ score has steadily declined or improved, I guess I would say, from 24 to most recently 17. She did have one very severe, what she described as a panic attack in January, and was also just having still some generalized anxiety. I haven't done a GAD score on her, but I did give her Atarax, 25 milligrams, which she's taking as needed for anxiety. After her panic attack and then a suicidal, I guess I would call it a gesture, in January, she took 7 Midol pills, saying that, I forgot how she described it, but it was something like she just wanted to, she didn't say she wanted to kill herself, she said she just wanted everything to go away, I think was how she described it. I saw her back. She actually saw another one of our counselors on an emergency basis that day, and then saw me a couple days later. But that's how I put her on Wellbutrin, 115 milligrams XL. She was no longer suicidal when I saw her. She said she felt like that. It was, I think she used the phrase rock bottom for her, and that she was not thinking about suicide. She's a healthy person, no other medical comorbidities. I want to give a little more on social history from my point of view, but my main question is, I often use Effexor and Wellbutrin in adults, but I haven't done it in teens, and that on top of the Atarax, I feel like I'm really getting out of my league. She does have an appointment with a psychiatrist in the area, but that's not until March, and they've had trouble getting her in sooner. She has found counseling very helpful. So this teen lives with her parents and her 2 younger siblings. Her parents are local business people and professionals. Her mom has been extremely supportive. I think that she the patient does not feel good about her relationship with her father. She feels that he doesn't support her and is somewhat judgmental of her, and it comes out as sort of sarcastic attitude.
I'm muted in case you want to.
And that is one thing that she actually identifies with to me as a source for some of her depression. She also feels stressed out about the usual high school senior pressures. She was recently admitted to a college. She was very pleased and excited about that. She has a boyfriend who she says is supportive. I haven't gotten any suspicion that there's any intimate partner violence of any sort there. Her mom tells me that she thinks that she just isn't fully engaged in her own improvement, and that there are things that she's been counseled to do that she doesn't do. The mom thinks that maybe this is because she's so depressed she just doesn't have the gumption to do things. And the mom's hoping that treatment will then help her to do some of the cognitive behavioral therapy that she's been recommended to do. I did talk to the mom briefly at the end of last week. It was only 2 days into the Wellbutrin, and the mom already thought she was doing better. So who knows what that was about? But that was, I'm happy that she said she was better. And I think that that's my main. I can no longer see the screen actually with the case on it, but oh, there we go. Oh yes. So my other question was, obviously I'm concerned that, even with improvement in her PHQ-9 score and these medications, that there's been another suicidal gesture or suicidal attempt. And then I also have wondered about bipolar disorder. There is a family history of depression. And to be honest with you, I can't remember. I do not think there's a family history of suicide, and I do not think there's a family history diagnosed of bipolar, but the mom did describe a family member. This would be second-degree relatives, grandparents, I believe, or aunt, uncle, who had some history that seemed questionable for a bipolar disorder through a manic depression. But the mom wasn't sure if it had ever been diagnosed. And so that was another one of my questions, with anxiety and depression and not improving. Should I be thinking about bipolar disorder? I think those are that's my history. And Savannah, are you able to add anything to that? You might be muted. Maybe not.
Savannah, if you do figure out how to talk, you're welcome to chime in anytime. And Jen, thank you so much. I think
You're welcome.
Case presentation. And I just wanted to ask everybody on the call, we have quite a big group today, if they had any other questions or comments or had seen similar cases like this.
I have a question. Is there any suspicion about eating disorder at all with a 16-pound weight loss, or any sort of like body image issues or like major sort of self-esteem issues that could be at play?
Right. When I saw that weight loss, I thought, oh my goodness, is this what we're dealing with? So I hadn't had any suspicion of that prior to, but it's certainly something that I've got to approach with her. And she's a very well put together, attractive young woman. I've never picked up prior to that on any question of eating disorder, but I don't think I've directly asked about it. And certainly I will be following up on that because I was really surprised to see that weight loss. I did just chat Savannah to see if she's able to jump in, but so far not.
Savannah, we can see that you're like muting and unmuting. I wonder if maybe there's like a mic setting that could be different.
There it is.
There's an up arrow next to the mute button in the bottom left screen. If you see the mics there, you can try to select a different microphone to see if that works. In the meantime, comments?
I have some thoughts. You want to go for it? Well, I wanted to start with sort of addressing the sort of concern about bipolar disorder in a young person. I think that's always reasonable to keep in the back of your mind. Almost all true bipolar is probably going to present with depression first. And I think anytime you see unresolved depression, it's something certainly to keep in the back of your head. It's very hard still, though, to take a depressive episode and sometimes predict who might convert to bipolar disorder or not. And so you always have to kind of be mindful of looking through sort of the symptoms converting. I certainly don't think until you see clear declaration of some things that start looking like that I would necessarily change your game plan, but just kind of make sure you screen for that. There are 5 sort of flags about depression that should make you think maybe a little bit more about bipolar disorder. I'm not sure that she has any of those. Certainly family history, like a true first degree, is definitely a risk. Sometimes if people have shown flipping behaviors on SSRIs or antidepressants can increase the risk. People that have like severe psychomotor findings and like lethargy may be at risk. Clear depression, like severe drops with severe dysfunction without any triggers, can be a risk. And then the presence of psychotic symptoms are kind of like the big 5 that can maybe make that a little bit more likely, but it really is very hard. And when they've tried to even treat high-risk people for bipolar disorder with bipolar medications, it really doesn't seem to help until they truly declare it. So as long as you're vigilant and keep an eye on that, I don't think you need to do anything different until some of that starts manifesting. Just keeping it back in your head, I think, is exactly the right thing to do.
Can you say those 5 again? I missed when I got family history, psychomotor retardation, severe depression, and psychotic features, but there was one that I missed.
Flipping from antidepressant medicine into like an activated or agitated state.
Okay. Oh, right. So an exacerbation. And is it true that venlafaxine can precipitate that more than others, or not so much?
I don't think we have great data on that. I mean, SSRIs were always sort of the big culprit. I mean, there's certainly been cases reported of that at venlafaxine and Wellbutrin. Actually, Wellbutrin's the one that has kind of the lower flip rate when you look at data, but I mean, in theory, they all can do it. I don't think we have great data on it.
Okay.
I think everybody's sensitive to it. Like with one medicine, you're likely to be at higher risk to have it with others, but I don't know how great that really is. So.
Okay. All right.
I think you've actually started out really well in the treatment of depression. I think you do have to answer the question of the eating disorder, because I think that's going to really, that would have big impacts on the medicine choices. Certainly if there's any purging behaviors, Wellbutrin's kind of risky. I think, we use actually venlafaxine all the time. It's actually considered a 2nd or 3rd line agent for pediatric depression. There were several really good studies. So if a patient fails two SSRIs, they almost always recommend you choose venlafaxine, so that's a good choice. Is she still on the Lexapro, or was that tapered?
No, I stopped that when I started the Effexor, yeah.
So you actually can keep going too with the Effexor in patients that have that anxiety or panic component. We sometimes encourage people to go all the way up to 225 or go up to 300, even though that's a little bit beyond if they're not having any side effects. Those higher doses can be much more helpful for the panic and the symptoms and like generalized symptoms in the lower doses. So we certainly have room with that. And with the venlafaxine, you're getting a little bit more of that, you're getting more of that norepinephrine response. You get a little bit more of the motivation, focus, concentration, sort of low energy symptoms. So that's certainly reasonable. I think combining Wellbutrin with SSRIs is also pretty reasonable. I wonder, in looking at like the change in her PHQ scores, sometimes like if you could, I don't know, even though she reported nothing was different, did you see any changes in anxiety symptoms or the energy symptoms or the sleep symptoms? Because sometimes if you can separate out kind of the symptoms, like I think if you're talking about really bad energy or really bad motivation, adding on Wellbutrin can be a pretty good way to target that, either with the venlafaxine or an SSRI. So I think, again, that's very reasonable. The weight loss could have been from the Wellbutrin. It can suppress appetite too. So I don't know if that was depression or something else, but you certainly have room to kind of work with that too, as long as the eating disorder isn't at play. So I have several things you can do. If the anxiety has been more problematic, especially with the panic attack, I'd probably still try to maximize the Effexor. Wellbutrin can be complicated with anxiety, I guess. For people with panic, some people report it really worsens panic, but some people that are so amotivated and can't focus, they actually panic because they can't focus, and Wellbutrin can really help with that. So I think that's sort of sometimes very much what she's reporting is helping. If mom's saying, oh my gosh, Wellbutrin's making a big difference, and you aren't seeing any of that worsening panic, you certainly have room to go up on that one to 150. But I think you're totally on the right track. I think a lot of it's tracking and kind of seeing and optimizing that. Certainly, if we can get Savannah back, I'm kind of curious some of the things that she's maybe shared in therapy that might be other targets.
Right, because she undoubtedly has some more in-depth answers to some of the things you've asked about, but that's very helpful. And I don't think the weight loss is the Wellbutrin because she's only really been on it for about 10 days. And I would have to look at her PHQ-9 details to refresh my memory. Oh, there's Savannah. Oh, she can't get her mic to work. She said she'll type out some things that she's noticed, so that's wonderful. The PHQ-9, I'd have to look at that to refresh my memory on the details of what her symptoms are. My impression is that it's been the anxiety that has been really bothering her more. As we've gone along, and I did warn her about Wellbutrin and anxiety. I sort of held my breath. I started her on a weekend, and I was like, "Oh man, I hope this doesn't worsen." But I told her, and I told her mom, and I said that often that can dissipate after a few days of taking it, is what I usually tell people. So luckily, it didn't seem to aggravate. So, and let's see. So Savannah is saying. She's been using CBT for therapy, learning assertive communication skills, a lot of negative self-defeating thought patterns. That's what you were asking about. But she's made progress on those.
Savannah, you had any concerns about eating disorder stuff or body image issue things that have come up?
She can hear us.
I'm sure she's just typing. Didn't want to.
Okay. Oh, there we go. Let's see. She said she noticed that she looked like she lost weight.
I think if you do start getting kind of some eating disorder pathology or some of the, or more of that true OCD control theme, I think you can. I'd probably be a little bit more hesitant about the Wellbutrin, especially if she's actively purging. If she's not, you're probably okay at 150. But I think when you're getting in kind of the eating disorder realm, the literature is a lot stronger for switching to something like Prozac, especially when the vaccine sort of doesn't really get it at the higher doses. And the target dose for Prozac for sort of that eating disorder, obsessional anxiety is about 60 milligrams. So I think if you get that, or if you would fail something like the venlafaxine, I think that could be a reasonable kind of next step until she gets into psychiatry.
From what you're saying, it sounds like the Wellbutrin with purging, that it's more than it's just an appetite suppressant. Is there a risk for seizure, or is
So that's the limiting factor with the Wellbutrin. So if you have a seizure disorder, you have conditions at risk for seizures, that's a kind of one of those big warnings on the Wellbutrin. And it's specific to the seizure risk. So in eating disorders, it's not necessarily the restricting or the cognitions, it's if they're metabolic instabilities. And
gotcha.
If there's active purging, that really can increase the risk. Depending on how bad the restriction is, that can increase the risk too.
Okay. Okay, that's very helpful. Thank you.
So that's active. I mean, I've certainly had patients that have had their eating disorders in remission, where I think you can kind of do that cautiously. But as I said, that's a lot of weight in a short amount of time to try to really figure out what's going on. Because if you really, again, if some of the energy things are going on and she's really restricting or not eating, you may be seeing just sort of depressive malnutrition kind of stuff that's gonna really work against all those medicines.
So Van,
go ahead, Caitlin.
added us again. I just wanted to read it real quick. She says, had one family therapy session with her and her mother, and she's wondering if everybody thinks it's a good idea to bring the father in for a family therapy. A lot of her stress lies with conflict and strained relationship with her father.
I would totally, as long as she's comfortable with that, I would definitely bring them in. First for initial assessment, with family therapy, I always kind of assess and see the patterns of interaction. So keeping it light initially, and then looking at how she wants to approach it, depending on what her goals are within that. I think that, as one of the things that you had talked about was a concern of her increase in suicidal ideations. And I think that sometimes what I see, especially in teenagers, is as you start to treat some of the depression, if they have some of those obsessive thoughts, then the suicidal ideations increase. And so really working on those self-defeating thoughts. I think if she's in a bad place with that, placing a hold on family therapy until she gets that under control. If you think she has a pretty good grasp on that, in utilizing her techniques to keep herself safe, then I would move forward with family therapy. Absolutely.
I'm glad Savannah asked that. Definitely her relationship with her dad is problematic.
Yeah.
Okay, well, that's very helpful for me. I'll wait and see if Savannah has any other questions, but I really appreciate the feedback, and I'll see how things go.
Thank you so much for giving the case, and thank you again, Savannah, for all of your insight. I'm sorry we couldn't get the mic to work there. Any other questions about this from the group? Perfect. Thank you. Thank you, Savannah. So Alexandrina, we do have a case from you. Are you okay if I share that so you can start? You're muted, but I hope you said you're good.
Can you hear me?
Yes, now we can hear you.
Okay. Okay, so let me see. Let's see the case. Okay. All right. So this case, before I talk about patient, well, I'm going just in some demographics. So she is 27 years old, single Caucasian female, is currently living with her maternal grandmother. I think she has been living with her for the last couple years. She does work full-time at a gas station, like as a cashier. So just to give a little bit of background before I actually saw her, I have seen her twice. One was a brief consultation following her medical appointment, and that was very short. And then she came back once for like a formal intake. And this was back in January. So I haven't seen her since. She scheduled follow-ups and she has canceled them twice. And she is now scheduled to be seen this coming Friday. So I haven't done any, treatment with her at this point, besides the intake. But before she came to me, she's new with our clinic. I think she first established care sometime in 2019 for like sinus and things like that. And I think she was seen like 3 times in 2019, and then she came back once in January. But my understanding is that she came once, I think at the end of December, to see her medical provider, and she was sort of like in a hypomanic state, according to what the medical provider mentioned. And she was able to consult with our psychiatrist, and it was diagnosed at the time with bipolar. She also said that she did have a bipolar diagnosis from back in 2010 when she was inpatient. She has been inpatient once when she lived in New Jersey. Now, the psychiatrist put her on lithium and Abilify, and the patient, she said, she left the visit and she had pretty much had a panic attack and in the car because she didn't want to take those medications, and she hasn't taken them. So she doesn't want to go back to see the psychiatrist. So then her medical provider, sent her to see me, and that's where we are. But going back to her, how she presented to me, so she endorsed when I saw her, she said like for the past 7-8 years, she has been, having mood swings, feel irritable. She snaps at people, others, poor concentration, feels restlessness, anxiety, and worries. And she says like these are kind of like on a daily basis and not something that comes and goes. She pretty much, she says, is present all the time. She also endorsed, hypersexuality, but she kind of clarified that it is not there all the time. It's usually when she is in a relationship and when she is not in her birth control pill. She also reported some impulsive behavior. She gave an example of, she had known someone for 6 months, and she, like in an impulsive moment, decided to leave her apartment and go live with this person. And she kind of lost, I guess, her, housing. And I think that's the reason why she actually had to go. Then the relationship didn't work out, and she had to go and move back to, live with the grandmother. She also endorsed, periods of feeling like sort of like a burst of energy and then kind of crashing. Sometimes some confidence level in the confidence increases, but it's not happened that often. She mentioned some rapid speech. What else? Overspending. She says she also overspends, but it doesn't seem like, again, everything doesn't happen like in nice like period of time. And so that's some of the symptoms that she reported. And this has been ongoing for 7 or 8 years, which was the time when she was inpatient. So I think she was about 18 years old. Her mom committed her. She said she was committed because she told her mom in a moment of anger that she wanted to kill herself. She denied that she actually had a plan to kill herself, or she wanted to kill, but she was really upset with her mother and told her that. And so her mother committed her. She was in the hospital for about a week. And then she saw a psychiatrist outpatient for a few months. She said she was in a number of medications. She really couldn't remember many of them. She did remember Wellbutrin and a medication that started with a C, but she didn't remember the name of the medication. She did stop taking the medications, not because she felt better and decided, I'm going to stop my medications, but more like because of the side effects of the medication. So that's part of the background. She also endorsed depression. She said, like, 4 years ago, she had a miscarriage, and during that, after that, she said, like, she went through this period that lasted a few months, where she just didn't care about herself. She stopped, showering. She didn't do her ADL. She wouldn't go to. At the time, she was going to school. She didn't go to her classes. She pretty much just didn't care about herself. And she pretty much says, like, her depression has persisted for the last 4 years at, different levels, but has always been there. And she thinks that if she lived by herself, she probably would go back to the same habits of not, doing any chores around the house. Right now, she kind of forces herself to do some activities because, she lives with her grandmother, but it's very minimum. Now, one of the things that she also, and I don't think is on the write-up, but she did say that after, going through the major depression, like the first major depression episode and the miscarriage, she developed some, compulsions and obsessions. So she obsesses a lot about wanting to have a child. That to her is very, seems like it's always in her mind. And she sees herself as this kind of caregiver. So, and I know I'm gonna jump a little bit, but as a kid, she said she was 7 years old when she started being the caregiver pretty much for the mother and her younger brother. She pretty much says she raised him. So she really sees herself as this, she's in the background. She always kind of took care of others. And so this idea of having a child for her is having something to take care of. But going back to the obsession, so she obsessed a lot about having a child, but also there are things compulsion that she engages, like she will unplug any electronic or like wires or plugs. She rechecks her doors, like the house doors. There have been times that she will, go to work or someplace, and then she will actually come back to make sure that she, lock the doors. She likes to have things in a certain way, either both at work and at home. She likes even numbers. Also because she's a cashier and, she sees different customers at work. She's like, if a person looks to maybe be sick or something like that, she will wash her hands 5 times, with soap and water. Not just one time, but she will go over it at least 5 times each time that, she interacts with a customer. She says if she doesn't engage in these, compulsion, she feels a lot of, she obsesses about it and she feels, more anxious. She also endorsed some panic attacks, but these, she says, they are triggered. They just don't come out of the blue and they're not, frequent. I kind of asked her, so about her sleep, she has difficulty, falling and staying asleep. She uses cannabis to help with sleep. And she has been using, I think, since she was 14 years old and pretty much on a daily basis. She described herself as sort of being a night owl. She will stay up all night if she could, and that's when she has some more energy. So she would, if she could just have an evening job, she would stay up all night, sleep all day, and then go to work. That would be her ideal, setup routine. What else? So going back to background, family history. So her father was in and out of her life. She spent some periods of time with him, but not that frequent. She was raised by the mom. There was a stepfather at one point. Maternal grandmother was involved as well. She said the mom was verbally, emotionally, physically abusive. Mom was diagnosed with bipolar, had a history of suicide, and patient described there were times when she was a kid, she would sit outside of her mom's room, just afraid that the mom would, commit suicide because the mom was saying that she was going to commit suicide. So our childhood wasn't stable, but a lot of fears and kind of a lot of responsibility, taking care of others. What else? No. So because she didn't take the medication that our psychiatrist, Dr. McKellen, prescribed, she wanted Wellbutrin because of, you know, the reported history of bipolar. You know, they didn't want to give her the Wellbutrin. So the PCP gave her Celexa 20 milligrams. That's what she's on. I'm not sure that, you know, if she's taking it because I haven't seen her. Now, one of the things that in like health history, it's not on the you know problem list. But then as I was going through the notes from the PCP, there was mentioning that the patient had reported that she had polycystic ovary syndrome, and I don't know if that's being treated or not. And I was reading a little bit about it, and that can affect the mood from what I read. Her PHQ, you know, was kind of along to the moderate severe range. GAD was, you know, severe, 20 out of 21. So that's kind of what I have about her. The PCP could not be here today, but she's, you know, wants to know what other medication might be more suitable for her. Is Celexa a good choice? Is there something else that we could she could prescribe? And if the, you know, if the patient is willing to take it.
Thank you so much, Alexandrina.
You're welcome.
Thank you. Does anybody else have any questions or anything surrounding this, or do you have any comments? Maybe you've seen similar things pop up.
I'm just curious about her cannabis use since it's daily and how that could be contributing, or I don't know.
Definitely. You guys have questions, comments?
Oh, I definitely have comments.
Yeah.
I mean, I think the harder place to start is with medicines, actually, to me, because there are so many diagnostic questions about what diagnosis really is. I mean,
Right.
the way you presented the case, I mean, nothing jumps out to me as classic bipolar disorder. I think that's what sort of strikes me. I mean, you really focus on a woman with pretty severe anxiety and trauma, a very bad depression and self-esteem. That just sort of jumps off the page, and I think, and maybe a history of ADHD and impulse control at baseline, and sort of not just the marijuana, but some comorbid alcohol use, drinking up to 12 drinks a day is pretty intense.
But the alcohol is not. So what she drinks a lot, but it doesn't seem like it's very frequent that she actually does drink. It's 10 to 12. Well, of course, it could be more than the 10, 12 times per year. That's.
And I guess I would say from a diagnostic perspective, I think one of the hardest things to do is to separate out what is true bipolar from substance use and trauma and really severe like OCD. I think that is diagnostically a very challenging thing that requires kind of getting that line down. And I mean, it's going to change which direction you go completely with medication choices. I mean, obviously the psychiatrist was pretty convinced, I think, about the bipolar disorder, having prescribed those medicines. Say based on the way you presented the case, I guess I'm less convinced. I don't hear any of those clear classic bipolar symptoms to really justify to me using those medicines, especially if she doesn't want to take them and they weren't helpful. I think this, again, is one of those things where you probably have to build some rapport, and if you aren't sure, you can do a lot of things with medicine while still warning her, talking about the risk of flipping. And I said the marijuana piece is also huge because there's so much worsening of mood and bipolar disorder that can come from daily marijuana use. It's so hard to tell what's what. So I guess my question is how convinced is everyone regarding the diagnosis? Because I don't think we can make great decisions about medicines until we sort of have a framework of what we really think makes sense, I guess.
Right. It seems that the PCP and the Dr. McKellen that saw her once are convinced that that she has bipolar. When I assess and ask it for clarification, because as you said, not everything like fits in a nice box. The mood swings, the hypersexuality, and they don't all happen all at once. It's kind of like all over the place. But of course, she has family history like mom, so that's relevant. But also given I try to look at the patient within the context and history. So given like her history with trauma and being a caregiver and her being kind of like not in some ways, mom, being abusive, talking about her weight. So she's also overweight. And that's, I think, maybe also one of the reasons that maybe she didn't want some of the medications because she didn't want to put more weight on. She is very self-conscious about that, it seemed like. I find it interesting that the OCD symptoms kind of developed after the loss, and I don't know that she has actually processed that loss. But what the way she presented in the room is that it seems like that sadness, that depression is always there, even when she's like all moody like that. It's so that's very very prevalent and is noticeable in the room. I think for me, I would like to know more about because it sounds like she started treatment when she went to the hospital in 2010. So what happened before then? Like how did she cope, and like what kind of like I think I would like to know more about what happened, because she was a bit guarded about like to her, she said that she was angry, but why was she angry? And like it's just like she just blurred out that she wanted to kill herself, and that was a reason enough to take her to the hospital. Was more going on at the time that we don't know. But also for someone if she does have bipolar, she has done pretty well, and she hasn't, that was the only hospitalization. I think she saw a therapist briefly after the miscarriage because, I think the school kind of, she wasn't functioning. But she hasn't been on any medication for, the last 7-8 years. And no history of, self-harm, no attempts to suicide or anything like that. So to me, that says a little bit about her. Also interesting that, work for her, she might not do anything else and has no motivation, but being financially independent is very important to her, because she mentioned that she saw her mom, depend on other, especially men, to provide. And she always said, like, I don't want to be like my mom. And so for her, like, being able to work and have her, her is a big piece. Another thing that she mentioned, I don't think is on the write-up, is she puts, and she showed me, she has like these at least 12 alarms in her phone. Get up in the morning, like, when she goes to work. And she will start, maybe, if she has to go to work, maybe like, I don't know, 10 a.m. She will start like at 4 o'clock in the morning, setting the alarms, and then, so that itself creates a lot of, fatigue and low energy. I would think it would be tired just because you're not really resting, even you think, but if you spend like 2 hours just, with the alarms going off every 10 or 15 minutes, I wonder how that impacts your,
So, I mean, from a strictly medication perspective, I think the point you made about that she stayed out of the hospital and hasn't had any full-blown symptoms off of medicine, I think you can feel a little safer to try things with good monitoring. She's obviously having trouble sleeping, and that's a big driver of her marijuana use. I mean, I think you could start with some simple things to maybe target sleep to get her to kind of buy into different treatments. Certainly, there's to be a very strong trauma component to some of her things and some anxiety. I mean, I think if you could get her to have a healthier choice in terms of medicine, try to off marijuana a little bit, things I might consider for sleep might be things like using clonidine, which is an alpha agonist that kind of helps with ADHD and anxiety symptoms at night, or mini press, that's more your like classic kind of trauma nightmare thing, and kind of help her get to sleep so that she has a better chance to be more awake and alert, and see if some sleep stability kind of helps both maybe decrease her substance use. It's completely weight neutral. She may have a little bit of buy-in to that. I don't feel that strongly about not trying the bupropion. I think there's some benefits. I think you have to be really cautious. You don't worsen anxiety. You can be really cautious you don't flip. But I think head to head, as far as antidepressants go, bupropion does have sort of the lowest flip rate in some of the literature. And it may be beneficial for her for other reasons. I mean, if she had some untreated ADHD, and maybe that's more the problem with her executive dysfunction and more of the problem with her organization. I mean, some of that dopamine, norepinephrine effect of the bupropion may provide her some of that underlying ADHD treatment and focus treatment to help her organize. It certainly would benefit her as an anti-smoking agent too, and maybe decrease her cigarette use. And help with weight loss again, as long as there's no seizure risk from the alcohol. I think you could do that in a different direction. Again, I think you have to be just very cautious and follow people closely to see how they respond. But I think that you could certainly do that. I mean, I'm totally impressed by the level of OCD symptoms you've presented, and it's not that uncommon to see that start after pregnancy. That onset is really not unusual at all. And so I'm not sure she's actually ever had an actual like medication trial for OCD. Now that gets tricky with the bipolar piece, because you're talking high doses of Celexa, high doses of SSRIs to even hit at some of those things. And again, that close monitoring would really have to continue. I mean, if she really starts having mood destabilization and more classic bipolar symptoms, you could try things like Lamictal or Latuda that are more weight neutral and get a little bit more buy-in. I mean, the lithium and the Abilify are going to be, really scary to people that are worried about weight gain, and so that's a big driver. And I think the Lamictal has a little bit more like anti-anxiety effects too. But again, I think a lot of this is probably getting her trust and getting her rapport and getting that buy-in to kind of get more of the story, and maybe just targeting some real specific severe symptoms and what direction you're going. Because if she has this amazing response to bupropion, I mean, you may really be treating underlying ADHD, and that may be far more the explanation of some of her mood dysregulation and impulsivity. And so I think it's kind of aligning with her and kind of picking up and just really following it through, because I mean, she is really complex. Very complex.
I guess I'm not the only one that's convinced she actually has bipolar disorder. I mean, I guess that without having more documentation and combing through the records and really actually knowing for sure if her mother, has that, that would be a little more genetic evidence pointing towards that, but there's so much, I guess, trauma and things that trauma can make it look like she has ADHD, which she's still gonna have, but I would actually go out on a whim and say this could be some cluster B borderline stuff potentially too. If you kind of look at the criteria for that, there's a lot of unstable self-esteem stuff going on. There's poor coping with, you know what I'm saying? I don't know her, so I don't know, but I'm saying that's a possibility and could potentially be a rule out and should be looked at.
Well, and I see that surface a lot after miscarriages too. And so sometimes that can really overlap and go hand in hand. And I've had a similar case to this, not quite the trauma involvement, but a similar case after a miscarriage where sleep was our major proponent. Like once she started regulating sleep, it shifted significantly. And so, and she did have some underlying ADHD, but it's that surface, like once we got to iron some of that out. But I think that, when I listen to you, it sounds like it sounds like the big trigger was this miscarriage, and it sounds like all this trauma was like exposed by that. And so I'm just, I go right to the trauma.
Thank you.
You're welcome.
It's hard too if she's not coming back to the appointments,
Yeah.
because then you can't really address any of that. It's like, because a lot of that work, I feel like if you're gonna do in therapy, even just that's half the battle, is getting them to come back to the appointment. Like,
And teasing those things out.
Yeah,
You need the time to do that.
yeah, whether it be support or therapy for the trauma, or just to have a conversation around what you think it could be, or OCD, whatever it is. It's like you got to get the person in the room with you. Yeah,
and I'm wondering if her cancellations have to do, because she will cancel after missing the appointment, has to do with actually being able to get up. I remember that for the intake, she was like 30 minutes late for the appointment, and she said it was because of waking up or getting out of bed. So I did call her either yesterday or the day before, and so she called back and rescheduled for tomorrow, Friday. So she, if she comes in, and then there's a lot of work that we can do. But again, it's if she makes it.
I hope she does, and then you'll get an opportunity to explore some of this.
Right, yes. Well, I appreciate the feedback.
Yeah, thank you for presenting. Did you have any other questions or anything that we?
No, just will you send a write-up with the recommendations for the PCP?
Yep.
Oh, you know what? One more thought I have is it might help to ask her what are maybe the top 3 things that because there's so much going on, but what does she think is the top concern for her? Does she say it's sleep, or does she say it's OCD? What does she think it is? Maybe she's already told you that, but do you know what I mean?
Well, what was interesting about when I asked about goals for treatment, what she said was, I want to be happy, which a lot of people say that. So then I asked what that would look like, and then she said about I want to have a normal relationship, I want to get out of bed and do average things, I want to feel physically and mentally okay, not worry so much, and love myself. So that's a lot, but I mean, I think those are the things that she struggles with.
And I would always sort of too, again, if you can get that rapport, I mean, the level of low energy and not getting out of bed. Really, I also would do a little digging to see if there's any underlying sleep disorders. Could she have sleep apnea, or is there some narcolepsy component? Or, I mean, because there's just so many layers of. I think your idea of trying to really get her to focus on her priorities is a really good one, because, as I said, I think you could start chasing one thing for the other if you don't have a really good plan. Oh, it's tough.
Jennifer Boyd had one question about the case.
I think this is quick, and it's about OCD. This was a really interesting case, by the way. Thanks for the presentation. Is it totally old school to use a tricyclic antidepressant for treatment of OCD? So I was thinking that, if you give her something something that's a little bit sedating, that would help her sleep, and then if there was some OCD.
Yeah, so the clomipramine, which is more serotonergic of the old tricyclics, is excellent for OCD. It's a really, you can actually use it as an augmenter in low doses to the SSRIs, or as a single agent, and it can really be helpful. And you're right, it's a little bit more sedating, so that can definitely be an option.
And you said that if you're using SSRIs for OCD, that you often have to push them to higher doses. Is that right? Okay.
Yeah, so you're looking the fact that she's on Celexa and it's only 20 milligrams. That's probably not even touching it. You're probably talking about, you're probably doing 40 to 80 of Celexa. Prozac's usually 30 to 60. You really get almost no benefit to OCD until you get to those higher doses. Generalized worries and depression, you tend to get more at lower doses, but you rarely touch the true intrusive obsessiveness until you get to the high serotonin level.
That's very helpful. Thank you.
Awesome. We only have 1 minute left, so we're going to end there. If anybody has any further questions or anything, please feel free to email and we'll get back to you. Our next session is on the 19th. As a reminder, it is going to be that 12:30 to 1:30 change. Please come for whatever you can. It won't be a disruption to come late or leave early. That's fine. And Molly Fletcher-Leggett, is that right? Okay. She's going to guest talk for us about supporting transgender children and adolescents. So everybody come and see it. All right. See you later.
Thank you.
Kill.